Hello, I'm Dr. John Ropp. I'm family physician at Palmetto Family Medicine and Senior Care in Hartsville, South Carolina, and I'm medical director of the South Carolina Medical Association's Advanced Care Planning pilot funded by the Physicians Foundation. The purpose of the pilot is to train healthcare providers, physicians, and their staff, their offices, on advanced care planning, what that means for them as physicians and their practices, and also as patients as they make decisions about their health care in the future. One of the most important questions you and our patients can ask themselves is, who would you want to make medical decisions for you if you were not able to? What would you do? Who would you talk to? Well, that's the reason we have gotten involved with advanced care planning, because that is one of the most important questions that our patients can answer for us and allow us to understand so that we can document it, get it into the medical record, and honor their wishes whenever they need it at the most important times of their lives. The Physicians Foundation considers this to be important, and we do as well. What we do with the pilot program is we identify practices where this is already being done, but we want to educate patients in a way that gets everybody on the same page. It's one thing to have the conversation. It's another thing to have your wishes documented and, of course, honored when it is most important. What we do in medicine is the most important things in people's lives in many cases. Healthcare is a very challenging world. And 5 years ago, something happened to me that I thought would never happen. I stopped seeing patients in the hospital on daily rounds. That's dramatically transformed the way I practice medicine. But one thing that concerned me the most was, were their wishes being honored at the time of the hospitalization and perhaps even near the end of their life? In the pilot sites, we hope to answer these questions for our patients and to educate ourselves, healthcare providers, nurses, and our practice staffs what advanced care planning is and how we can honor patients' wishes.
I am a family physician in Anderson. I am the immediate past president of the South Carolina Medical Association, and I am quite pleased that the SCMA has taken the Advanced Care Planning Initiative and working to implement it throughout the state. I am in Anderson. I am in private practice there. We have 8 physicians, 5 nurse practitioners. We have 2 locations. Our main practice site is in Anderson. We have a satellite office in Belton. We have a patient population base of about 45,000 patients.
I'm a family physician in Lake City, South Carolina. I've been practicing for 25 years in the full gamut of primary care. I've had the opportunity to practice in the office, nursing home, inpatient care, and even home visits. I practice in a rural area. This high poverty is very challenging but very rewarding.
I'm a private practice physician in Sumter. Started out my training doing family medicine. And third year of residency, really got passionate about geriatrics and went on and did a 2-year fellowship in Connecticut. Really touched my heart with the areas and the facets with which our older adults, our training through medicine really doesn't match their needs.
I'm a registered nurse, and I have been working in the field of hospice and end-of-life care for probably more than 25 years in various roles. Currently, what I do is I work with hospice and palliative care providers around education, compliance issues, looking at regulatory concerns, and as well as what do we need to do to really meet the needs of consumers throughout our state.
I'm a registered nurse, and I work at Roper St. Francis in Charleston, South Carolina. My early nursing career was 28 years in the emergency department, and I saw a lot of families torn apart when their loved ones were in the hospital and they were at the end of their life and the family couldn't agree on what needed to be done. And that led me to work with this project that we're going to be talking about.
Research supports the efficacy of advanced care planning and confirms the need to increase activities to educate both providers and patients about the process.
It's hard to put into words the importance of advanced care planning. I think first and foremost it is a quality of care issue. And I think at the other extreme there are the costs involved when advanced care planning has not been appropriately discussed and implemented. Historically, I think advanced directives, which are certainly a part of advanced care planning, are a point-in-time effort, and usually it occurs in a critical or crisis time or situation in the patient's life, and decisions are made perhaps hurriedly and under pressure. There's a lot of second guessing, and it's somewhat of an awkward situation most times, and perhaps not the ideal setting in which to make these most important and critical decisions.
I feel that advanced care planning is a benefit because I have the opportunity to discuss the patient and the family's wishes in a comfortable setting, because I have been in uncomfortable situations for the patient and the family where they've been in the ICU under critical conditions and everybody feel pressured and uncomfortable to make life-changing decisions.
It's not uncommon for a patient to end up at the emergency room and have a great need and be in a critical condition, and yet the discussion related to what do you want done if you can no longer speak for yourself has never happened. The discussion around if you were to stop breathing, what would you want us to do, is now a shock to that individual because it was never introduced earlier. And so one of the things that we feel is very, very critical is that we need to be getting out and connecting with individuals in all of our communities, particularly rural communities and particularly minority communities.
In 2014, the Journal of the American Medical Directors Association, JAMDA, published a meta-analysis on the efficacy of interventions designed to increase advanced care planning. The following benefits were identified: an increase in completed ACP and end-of-life discussions, more concordance between care preferences and delivered care, increased communication quality and satisfaction with care, and reductions in conflict related to decisions and use of health services.
Advanced care planning should be more of a lifelong process that really could and should begin at any age and any setting, from the dinner table to the church to civic organizations and, of course, in the physician's office. It's so important for all of us to have these discussions about our goals, our dreams, our quality of life, what we want at the end of life, especially if we're not able to make our own decisions.
The instances, I would say, are innumerable. The number of times where I've seen the benefits of a prior discussion about advanced care planning, be it hospice or code status, or even just power of attorney. I've had multiple instances in my own practice of where we may have had the conversation years prior, not knowing when we may need the information.
I think the most appropriate setting is in the office setting or in the patient's home, where we discuss advanced care planning in a comfortable setting, no pressure, and the family and the patient can inform the medical team of their decisions. It improves the quality of care and the quality of life for the patients.
Many times when you're thinking about advanced care planning, people immediately go to death, because when you think of hospice or palliative care, you're thinking of people who are seriously ill. But one of the things that we have found is that having these conversations need to happen sooner than later. And that is very important for us to get the message out to all of our citizens, especially those who are vulnerable, and particularly those that may be in underserved populations.
When you're in a disastrous situation where the patient's health is in jeopardy, or they're not able to make a clear decision for themselves, having planted those seeds with the family, it helps everyone involved. It helps you as a provider caring for the patient. It helps the family in going through the process of coping and making a decision. Very few of us make good decisions in crisis moments, and especially when it's dealing with the health of a loved one. It's hard to make clear decisions that you will feel comfortable about for the rest of your life without having thought through it before. And I think this is one of those areas where, as healthcare providers, this is one of our most valuable roles, and we need to do it well.
By having these types of conversations, it opens it up to them to think about, what is it that I like? What is it I don't like? You may get them to say something like, I don't want to die like my mama died. Your next question is, what about your mother's death bothered you? That's going to tickle out from them something that's important to them. You can see that, and you can bring that back into the conversation when you start making decisions.
While there is no question that advanced care planning is valuable for patients, their families, and healthcare providers, many articles call for an increase in education about the process and its many benefits. The Institute of Medicine, IOM, released a 2014 report entitled Dying in America: Improving Quality and Honoring Individual Preferences Near the End of Life. The report confirmed the need to create a better understanding of ways to improve participation in advanced care planning and shared decision-making about end-of-life issues.
So I think it's very important for us, particularly organizations such as SCMA and my organization and others, to really connect with the faith community, because that's a huge area in the African American experience. The church is clearly one of the biggest, organizations that has the most influence in our community. Everything revolves around what's going on in the church and how it impacts those members. So I feel that we have a lot of organizations that are involved with that. Parish nurse associations, those nurses are in communities, they're in churches. And that as we connect and begin to get this message out, that it's okay to plan for the end. That just like we plan for our children's education, which of course, as I was growing up, that was the focus. Get a good education, get a good job. That was the push for African Americans, to make sure their children had great education, good opportunities. But just like we plan for that, we've got to also take that message about planning for the end, that we don't leave that to chance, and that it's not a problem to articulate those wishes and then to put those wishes in writing.
I think being in private practice also presents different challenges than in the hospital setting. Whereas in the hospital setting, there are perhaps designated hospital employees who are appointed this role of advanced care planning and can go into the hospital-owned, so to speak, practices to further this cause. But I think there are ways that we in the private practice setting, in the hospital practice-based offices, in the communities, including the hospices, the churches, the civic organizations, can work together to begin to educate the people of our communities and across our state about this most important topic. And again, I'm just so pleased and proud that the South Carolina Medical Association, through the foundation, has taken this on as a statewide initiative.
We've grown a lot, and we've been able to address needs in our patients much better. Probably my favorite part, though, has been the formal training. As most physicians will tell you that, we get some interview skills, we get some coaching on how to word things and how to phrase things. But when it comes to advanced care planning, it's really a kind of on-the-job training. Unfortunately, traditionally is a little bit of a by the seat of your pants approach, and to get formally trained in how to be sensitive to the patient's needs and help them think through their desires and think through uncomfortable situations has been tremendous, and I'm happy to be one of the pilot sites for this program.
An article entitled Advanced Care Planning, Just Do It was published in the Journal of Post-Acute and Long-Term Care Medicine in 2014. It confirmed that ACP discussions do not occur as often as they should for a variety of mostly clinical-related reasons, adding that patients tend to welcome these discussions and don't feel depressed or anxious afterward. This article stated that when clinicians do not promote ACP and initiate appropriate conversations to identify end-of-life care issues, patients and their families often have to make decisions that may not be in accordance with the patient's previously expressed wishes.
I have found myself in the position as a nurse and a healthcare executive that I'm sort of a resident person in my church and in my community when these discussions come up, and I'm explaining to people about what needs to happen. I find that physicians many times are uncomfortable with having the conversation. So number one, our physicians need to be educated about how to have difficult conversations, but they also need to know what are the pieces that they need to connect for one of their minority patients. If they have an African American senior who comes in, they need to understand that this is a person who believes that God is going to heal them, and that that's their faith tradition. And that number two, that this is not something that's an easy discussion, and that not just the patient has to be involved, but the entire family needs to be involved.
I really have found through my practice that the best way to have a good discussion about wishes and desires for the end of life is to have a relationship with the patient and a relationship with the family. That's not always possible, but usually that is the most fruitful way to have that happen. When you have a rapport with the patient, when you have a rapport with their family, in my instance, patients and their children, it helps them to trust you. It helps them to know that you're not coming with an agenda or a bias, and they really value the advice. Advanced care planning is just that. It's a relationship discussion with somebody. They need to trust you. They need to know that the advice that you're giving is not biased, that it's not slanted. And when you can do that well, then the conversation goes so much better.
In our practice in Anderson, we are in the early stages of implementing more extensive advanced care planning. And there are challenges, especially in the private practice setting. And the number one challenge is having the resources and time to implement.
In traditional medical practices, it's a area that some people do sometimes, but it's not a formal part of our training. And the job that they're doing in trying to move this forward has been a tremendous learning experience, even for me, but especially for other members in my practice.
It's tough, and it's recognizable. Other things are that in medical school you weren't taught to have this conversation. And it's a special conversation. It takes special skills. And part of this project is about teaching you how to use those skills.
In a 2015 report, the Kaiser Family Foundation confirmed that 89% of people believe doctors should discuss end-of-life care with patients, while only 17% report having these conversations. According to the JAMDA study, the most frequently reported reason for not having an advance directive was a lack of awareness about the process and its importance.
There's so many demands in the constraints of the typical office visit that to add one more thing to the patient's plate, to my staff's plate, to the physician's plate is quite challenging. Having said that, we're finding ways to overcome those challenges.
As Dr. Meadows said, the workflow in a modern medical practice can be complicated. Each physician's practice is different, so one size or method does not fit all. A good template to follow is utilizing all personnel. When a patient visits a doctor, the first point of contact is a reception desk. The receptionist is an excellent starting point to demonstrate the office's commitment to ACP, and can ask the patient if he or she is interested in talking about advanced care planning. If the answer is yes, the receptionist can provide a letter explaining the physician's commitment to this important process. Most office visits begin with a blood pressure and weight check. During this time, office personnel can mention ACP again. The physician can then ask about the patient's interest in ACP. If the answer is yes, the physician then provides a brief overview of the process. The next step is referral to the designated trained office staff member for an in-depth discussion regarding the patient's values, beliefs, and goals of care. The physician closes the loop by reviewing any completed documentation with the patient and has the document entered into the medical record. Again, this is a suggested template. Each office should identify what works best for their office, staff, and patient population.
In my office, 5 of us have been trained in the first steps of advanced care planning, and we are beginning to set aside half days that'll be designated for folks to come in for those visits. We've also talked about the possibility of just having group sessions, even if it's on Saturday mornings or Sunday afternoons, to introduce this concept to the groups and then invite them back individually for the formal advanced care planning sessions.
So one of the things you can do to start the conversation with your patient is, number one, tell them you want to start having this conversation. It's part of good patient care. This is something you want to do. If it makes you nervous to talk about end-of-life care, or if you think it may make your patient nervous to talk about that end-of-life care, tell them it's part of good patient care and you want to talk to them about how they want to live at the end of their life. Think about knowing ahead of time that your patient wants full treatment. No matter what, do everything. That's their choice to make. We can do that. Think about how important it would be to your practice and to know that your patient wants limited treatment. You can do everything you want, just don't put a tube down them. Think about how important it is to you and your patient both if your patient just wants comfort care. They want to be pain-free, they don't want to be in respiratory distress. We're not going to resuscitate them, we're just going to let them go peacefully.
One key to increasing the number of patients who benefit from documenting their end-of-life wishes is working with insurers to encourage coverage of ACP conversation by clinicians. In January of 2016, Medicare began paying healthcare providers for advanced care planning discussions with Medicare beneficiaries. In order to bill for ACP conversations, providers are required to have face-to-face conversations with Medicare patients and/or their surrogates and cover the patient's specific health conditions, options for care, what care fits best with their wishes, and the importance of sharing these wishes in a written directive. There is evidence that more private insurers are beginning to cover these conversations.
Tina, thanks for coming in today. I know we've talked a lot about your health and annual well visits and making sure we've kind of checked on all that, but there isn't something else I want to ask you, and it involves something called advanced care planning. Have you ever heard that before? We call it ACP for short, and basically it's getting an idea of what your wishes are whenever you develop health problems. So let me ask you this question. If you couldn't make medical decisions for yourself, who would that person be that you would want to make those decisions for you?
My spouse.
Yeah. Have y'all ever talked about that together?
No, we really haven't.
Have you ever met with someone and documented what your wishes might be, something called an advance directive, or have you ever filled out something called a healthcare power of attorney?
No, I haven't.
Because in our state, there's 2 types of powers of attorney, and some people know about the financial one, and they maybe have heard of a healthcare power. But that would be the person that you would designate to make decisions for you. And I think it's really important. But would you mind if we made an appointment for you to talk with someone in our office? Shannon, you know her.
Yeah.
She's one of the nurses here.
Yeah.
Well, she's been trained to talk to folks about advanced care planning. Would you mind talking with her maybe sometime and talking about what that might mean for you?
Yeah, that sounds good.
That's great, because even though people have talked about advanced care planning and maybe even have gotten documents filled out, physicians in our practices, we don't have access to those documents. We want to make sure that we have in the right place at the right time whenever you need it the most. And Shannon can help us do that.
Okay.
So at some point, I'll be glad to make the referral. I'll talk to the nurses here today even and get that scheduled whenever you can make it.
Okay, that sounds good.
Okay.
I appreciate it. Thank
Absolutely. Any questions for me?
you. I can't think of any right now.
Okay. Well, again, thanks for coming in today.
Thank you.
The challenge in making ACP an important part of healthcare delivery is to bring a wide selection of partners together to work toward this common goal. The JAMDA article just referenced summarizes this challenge well in the following paragraph. for the millions of Americans who work in or with the healthcare sector, including clinicians, clergy, caregivers, and support staff, providing high-quality care for people who are nearing the end of life is a matter of professional commitment and responsibility. Healthcare managers, payers, and policymakers, likewise, have a responsibility to ensure that end-of-life care is compassionate, affordable, sustainable, and of the best quality possible.
I want to take a couple of minutes and talk to you about advance directives. There's a number of advance directives available in South Carolina. The 3 that are recognized by the legislature is the Healthcare Power of Attorney, the Living Will, and 5 Wishes. The Living Will is a form that it only applies in a very narrow scope. It's if the patient is terminally ill or permanently unconscious, and that's the only time it happens. The healthcare power of attorney, on the other hand, is somebody that the patient has appointed to be their agent, to speak for them when they cannot speak for themselves. And that's a very important point that you want your patients to know. As long as they can speak for themselves, they will. The healthcare agent appointed in the healthcare power of attorney only speaks for them when they can't speak for themselves. This can be for any healthcare decision. Not just if they're terminally ill, not if they just have a permanent unconsciousness, but for any healthcare decision that needs to be made as long as they can't speak for themselves. 5 Wishes is a different type of form. It's more of a booklet that a company has put out so that people can think through the process of what they want. And it's a great way for people to come to the conclusion of what they want. It would still be great if they could complete the healthcare power of attorney. The one that's most helpful to you as the physician is going to be that healthcare power of attorney, because you'll have a person that you can speak with when you need to know something for your patient.
The South Carolina Coalition for the Care of the Seriously Ill, CSI, was created in 2010. Its goal is to develop uniform processes for communication, consent, and decision-making that will be recognized and accepted statewide and used regularly by physicians and others caring for seriously ill patients. CSI is comprised of physicians, representatives from hospitals and hospice organizations, the Lieutenant Governor's Office on Aging and South Carolina Health and Human Services, the South Carolina Bar, and more. These partners come together to focus on improving access to ACP and improving the quality of life of the seriously, chronically, and terminally ill in our state. CSI meets monthly at the South Carolina Medical Association.
POLST stands for Physician Orders for Life-Sustaining Treatment, and it is used in many states across the country now. It is for a more narrow population of patients who are at the end of life. In fact, one of the sentences we describe POLST as is, it's appropriate for a patient who would not surprise you if they died within 12 months. This language sounds very familiar to hospice, of course with its 6 months criteria. Advanced care planning, however, particularly in the primary care setting, is something that we can talk about with our patients no matter what health status they are, no matter what diagnosis they have, or really how old they are. In our pilot program, we're using the Respecting Choices First Steps program, which approaches folks of all ages as long as they're able to make medical decisions for themselves. So we would not include adolescents or those who, for some other reason, would not be able to make medical decisions for themselves right now. But First Steps allows us to talk to those patients and have conversations over the lifetime concerning what their wishes are and who they would want to make medical decisions for them. The relationship between post and advanced care planning could be summarized in this way. Advanced care planning does provide for advanced directives to be filled out and documented and honored, whereas post is a medical order that is used across care settings and transfers with that patient so that their care wishes are honored in each setting where they go. In this way, there still requires education, it requires conversation, and there is a relationship between post and advanced care planning beyond just what we see in one setting versus another.